make it worse. You know, like we're maintaining the stands, and obviously he's working all the
To me, it's a public service. I know.
I agree. Appreciate your service.
Oh, yeah. You know, you can just do that. You just go ahead and use it.
Person I run into? Charlie.
The nurse?
Yeah.
He was my
Yeah,
home.
that's what I think they did.
Jen is having a phys teacher.
I know they use
I used to sneak in
here
over
with the
the
meds and the lounge or whatever. But I knew I heard that. I figured that's what they were going to do, but.
Last year. Yeah, he was there with a small Greensburg.
That's why I said I did.
Yeah.
I know he came anyway.
I remember
To see how much was left, I would like yeah. Switching batteries. Yes, yes, we did. In fact, actually, his sister was there.
Joe, I think I saw your Reagan used to do that a lot too.
We need to move, but I want to make sure this is going to work for the next 5 minutes. So she called, this was loading up, and I just spoke with her. She's on the air running, we're like, yeah, it's running. I just want to make sure that it's not going to. She goes, it's just a type of for maintenance. So they should sorry, but we'll leave it fast. We'll pick up when we get there. And they were happy with that. But
Let me see what I can do. Hello, ladies.
Huge.
but I'm like, you know what? We're going to call and make them say no. And then everybody say, well, I didn't really say no.
Yeah.
So. Which actually is the I was ready for it though.
All right, let's get started. Okay. So call to order the meeting. Approval of the minutes. Any additions, deletions, corrections to the minutes from September?
We got the first order of business. The Esperance Rescue Squad is seeking REMAC approval for their new agency medical director, Dr. Joseph Luss, who is with us today. We welcome him.
Yes, this is Dr. Lowe sitting next to me. This is, and he has a number of squads, and this is an additional squad for Esperance. So, all those in favor? Aye. All right.
The Unadilla EMS seeks REMAC approval for a return to ALS level of service. They now have a paramedic on their roster, and I have all their paperwork. Their paperwork is in order. I sent a note around last month by email to the REMAC physicians, and Dr. Markowitz replied, but nobody else did. So we have to bring it up at the meeting now. But they are seeking approval, and all their paperwork is in order.
So they downgraded from ALS?
Yeah, they were down to BLS, and then they got a gentleman who got credentialed as a paramedic in the region. He is now with them full time. gentleman by the name of Josh Greenman, so they're all set to go.
And their medical director is?
Me.
That's what I thought.
Dr. Markwood.
We've also got another state trooper who is an AEMT. So both these guys are state troopers, AEMT, who will be graduating within about the next month.
Okay.
So we'll have two.
All right. Any discussion? All those in favor? Aye. Cherry Valley?
Cherry Valley Fire Department Emergency Squad has presented us their controlled substances operational plan. That's just a matter of information, but it has apparently been approved by the Department of Health as well, just to let everybody know that they are now online with controlled substances.
And who's their medical director?
You would ask me that? I'm not really sure. I'd have to look at the...
It's Dr. Fanning.
They had to sign off on it though, right?
oh yeah, it's all,
Yeah.
all fully signed up, yeah.
Okay.
Fully signed up and presented to the state. They presented it to the state and then sent us a copy.
All right, so this is just for information, really.
Right.
I believe that's Dr. Fanning.
Thanks. Sydney EMS has sent us a copy of their new license as a controlled substances agency, and again, that's just informational. They wanted us to be aware that they are now online also as a controlled substance agency. And the Worcester Emergency Squad is seeking a change of paramedic level of service upon certification and credentialing of a new paramedic, and this is informational pending his credentialing. Sid can advise us what the status is currently.
That student is in class in Utica, and we were advised by Mary, the state, and both of you guys, I guess, to seek a provisional credentialing for return to paramedic level.
They're already ALS, right? You guys are already ALS?
Yes, oh, yeah.
Is paramedic a separate, I mean, I know it's a different level of individual
It'll allow
provider
him to
level.
get reimbursement. During the course of an investigation regarding an entirely different matter, it was discovered the agency was not at that level, and
It's not at what level?
at the paramedic level, so it couldn't even be vouchered for.
So this is an additional step that
Correct.
enables some other activity.
Right.
All right,
Now,
that's
the amount-
informational.
The
Okay.
Mountain Lakes region has sent us a proposed memorandum of understanding seeking the approval of our REMAC. There are two agencies based in Hamilton County, namely the Long Lake Rescue Squad and the Indian Lake Ambulance, that are overseen medically by Mountain Lakes physicians and the Mountain Lakes REMAC, simply because their destination areas are all in the Mountain Lakes region or further east. Mountain Lakes has, it's a pro forma thing. It's just renewing the memorandum of understanding that we've had for some years. The Mountain Lakes REMAC has signed off on it and requests that our REMAC also approve their Mountain Lakes continued oversight of the Long Lake Rescue Squad and the Indian Lake Ambulance, simply because Long Lake and Indian Lake travel into the Mountain Lakes catchment area and the Remo catchment area exclusively. They practically never come down this way. God forbid, because I say God forbid, it would have to be an absolute monster MCI for them to come down this way. They're so far away from southern Hamilton County. So in any event, that I have a copy of the MOU here, and it's very pro forma, and just requesting that the REMAC doctors approve it, and Dr. Leinhardt sign off on it.
So this is just an issue where the geography of the region doesn't conform to the medical oversight and the,
Exactly.
and the REMSCO oversight?
Right, exactly so, yeah. They are, all of their techs are credentialed through Mountain Lakes, and that has worked out very successfully over the years. And this is just a renewal of that MOU.
Okay.
We don't credential those.
We don't credential them at all. I mean, Mountain Lakes advises us closely of what's going on, obviously, but we don't, I know who they are and have all their data, but as far as credentialing and re-credentialing on a yearly basis, Mountain Lakes takes care of it and has right along.
So this is up in your neck of the woods, right, Phil?
It is, yeah. Indian Lake is 25 miles north of Speculator, and Long Lake is 55 miles north of Speculator.
So you would recommend this?
Oh, absolutely, yeah.
Okay.
The system has worked extremely well with Mountain Lakes overseeing. We have close cooperation with Mountain Lakes, and all information is shared.
All right, you're gonna pass that down, the MOU.
I will do that.
Okay.
There's no DOH regulation?
No?
Joe,
It's as long as there's an,
as long as there's an agreement?
yep.
Move on in.
All right, next item.
You're right with you.
All right.
Check, you guys worried.
Yeah, 'cause you guys haven't done it, that's cool.
More meaningful discussion.
It goes to Gus. Okay. The ambulance service of Fulton County notified us on the 21st of October of their intention to begin the credentialing process for specialty care transport. I sent some information about that around to all the members yesterday by email, just for them to take a look at. And the ASFC has advised us just for informational purposes at this juncture and for discussion. Eventually, this will require REMAC approval, but this is early in the process. Roy Sweet from Fulton County is here, as is Mike Tracy, and Tom Gully also from Fulton County. So they would be able to answer any questions and take part in the discussion.
Could the folks of the state or the regional council maybe describe what the process is to become a specialty care transport agency? You're entering into some beyond paramedic level of certification. Is it a certification?
No, it's an endorsement by the REMAC, with permission of their agency medical director.
To do what?
Primarily interfacility transfers.
Are they barred from that?
They're not barred from it, but it allows them, what it does is it allows them to do, like, I'll use LifeNet, for example, okay? Or no, that's a bad one. But Mohawk, I'll use Mohawk Ambulance in the Remo region. Deb Funk at the time was their medical director, and she said, we'd like to approve them as a specialty care transport. We're going to give them additional training in the following. They went with classes of drugs, calcium channel blockers, sedatives, etc.
Sort of beyond the EMS?
Beyond the basic stuff that you're learning, it's a more in-depth training. And the way it works with them is any call received, the medical director could say, no, this is beyond your scope of practice, I'm not comfortable with you taking it. They have to send a nurse or whomever with the patient.
Are there certain modalities get kicked into this, like antibiotics, blood?
Blood is a whole special, that's a whole different thing.
Other thing.
Okay,
So
unless you have
antibiotics,
credentialing
maybe.
for blood, you still need a nurse with you.
And it's outside of 30A.
Correct. The interfacility isn't covered.
Explicitly in
Correct.
Article 30?
Yes.
Okay.
It's not, I'm sorry, you said primarily interfacility, it's only interfacility transports, correct? They cannot
There have
use
been a
it-
couple, if a person is cared for at the residence to a facility, that's not an EMS call. So say you have someone maintained on a vent at their house with all types of meds and stuff. That would be an example, and that's why I don't want to say it's only in a facility, because there are those odd examples.
And is it,
Tom, feel free,
The only comment that I have, and I'm in the same predicament, this REMAC has held our hand or chained our hands on certain procedures and certain medications that we carry with our SCT program that we cannot use in the field. So,
like an example?
propofol,
Right.
Valium, because the protocols don't have that. And,
Right.
and this REMAC has taken the stance that if it's an EMS call, that we cannot use what's outside of our protocol. So in essence, the only thing I do think that the REMAC has to or should endorse it, or be someone to endorse the programs. The only really thing that really pertains to us as SCT is the MFI credentialing process. And I think that we need to, as a REMAC, come up with some sort of credentialing process. I know when I came here to do MFI years and years ago, we had to supply all sorts of information. How we were going to get credentialed, what our training was going to be, What is our continuing ed? You know, every 6 months we're doing airway classes. So I think that those things need to come, you know, once that approval is, or comes, but I don't, unless we're going to reverse a decision, and I'm fine with that too, allowing us to use certain medications in those cases.
Yeah, I think that's the fuzzy area for me is like, is this a defined curriculum? Specialty care transport? The following procedures, the following drugs. It's
New York
not
State does
defined.
not have a recognized training program.
It's not defined, so it's just kind of like this, you know.
It's education in really, I'm sure they're no different.
It's a medical
We
director
work with the
defined.
hospitals because, and an interfacility transport, we're an extension of the hospital.
Yeah.
So we've worked with the hospitals into what they're comfortable with, and we've tailored our programs. We're not doing balloon pumps.
Right.
That's a, you know, if someone's on a balloon pump, they really need a helicopter. But we, you know, there are things that are definitely above and beyond.
Yeah, the hard part for the sending physician is we don't know what that is. We don't know who's had what. And the idea of getting hold of the medical director in the heat of the moment, I think.
That's something that the agency has worked out.
Correct.
On the end, when they receive that call, they have a method, the agency takes care of that. They get all the call information, similar to calling a helicopter.
Mhm.
They take the patient information, they call their medical director, hey, you know, what's up with this type of deal? And then before the call is accepted, it's cleared.
I believe last time it was brought up here, the issue was from, or it was brought up from Joe, and correct me if I'm wrong, that the two should never cross. That the SCT and the EMS portion had to be separate.
They really shouldn't cross at all.
Dr.
Like
Leonard?
Mary said, that there may be those unusual instances where you would have to send a specialty care team to a hospital. For the most part, they should never.
What Empire's done is they've got a list that they send to the hospital. These are our credentialed SCT medics. These are the medications they may take. They have to be on a pump. And that way, the hospital, besides our dispatch center verifying, yes, we have an SCT medic, the hospital can also say, yeah, Mikey medic there is on the list. This is a good drug. Okay, you have your orders. You're good to go. So there's a check and
We're going to
balance.
rely on the agency to tell us that at the time of. But,
Yeah.
so this really is just, this is information. So Fulton County Ambulance is going to hook up with their medical director, and their most common source hospital to work out some kind of extra skill set that serves that hospital in interfacility transports. Is that basically what it is?
Yes, we've contacted our medical director, Dr. Lem. We've been in constant contact with Nathan Woodford Hospital, Dr. Fisher, to set a set of guidelines of what the standards are for these paramedics that are entering this program, what the continuing education is, and what the standard is. And the standard that we chose, like you had said, SCT within New York State just means anything above, and it's a very vague area. What we did is we took even though New York State is not a critical care paramedic endorsed state, we've taken the national standard curriculum of the critical care paramedic and used that as a guideline, and sat down with Dr. Glenn and hammered out some protocols and some procedures and who is to be authorized. Dr. Glenn receives, it's one-on-one. He checks off on who is, he has the final say on who gets the clearance for SCT and who does not.
Okay.
And it rests entirely up with him, not with
So-
us, as far as who is.
Within this program will be fairly defined. I mean, the curriculum will be defined between Dr. Glenn and Dr.
Yes, we
Fisher.
have a very clear set of protocols that Dr. Glenn hasn't. There were some revisions were being made, so we haven't made it public yet. But there is a set of very fine protocols of what medications can be taken, what can't be taken, what's what's running on a pump, what's not running on a pump, and these are the medics that are credentialed, much like you would give the notify paramedics and CCTs that are on the controlled substances plan. So the hospital has been working very closely with us to try to work this program out. Dr. Glenn's been great. So it's a lot of course material we've required our paramedics to take. We're following national curriculum guidelines of 96 didactic hours on top of other credentials as well.
And from the hospital side, without this service, they'd be sending a nurse in most of these cases.
Yeah, they're, otherwise they'd be spending a respiratory tech, a nurse, which are kind of operating outside their field of
Right.
comfort.
It's the inverse of what you got.
Yeah, it's kind of inverse. So we're not looking at this time to go to the REMAC with MFI credentialing for the field. This is strictly for our inter-hospital transports. You know, at a later date, you know, maybe that could be revisited as far as MFI credentialing, but that's not what we're looking to do at this time. We're trying to build our SCT program, get that up and running, and you know, move on from there.
Okay.
Tom, just a question. The way our standards are written for SCT, obviously we have standards above and beyond protocol. But I'm going to assume that your vent medics, or anybody that's taking this class, that's going to transport a vent patient, is going to have the ability to certainly MFI, paralyze, or furthermore sedate in case of an accident or in case something happens en route. So I do think that portion has to come. At least whether or not the agency chooses to do MFI in the field or not, MFI is still a procedure under the protocols.
True, and we're training them as, you know, the same standards as MFI. We're just not looking to use that modality in the field for 911. That makes we're not looking to call for signal 41s or do MFI in the field at this time. We're training them on the vents, and we're training them in the same procedures that you would sit through an MFI class. We're not looking to initiate any of that. For example, coming from Nathan Latour, their medications, the patient would already automatically be sedated, and their medication of choice for them is propofol that they would use. We're not looking to carry any of that, and it's been very, very clear that that's not, you know, kosher out in the field. But if the patient is on propofol with Nathan Latour, we're looking to work with the hospital to be able to continue that treatment throughout the hospital, throughout the transport. Because currently, right now, a patient that's intubated is being put on, kept down with fentanyl and Versed, which is a horrible way to transport somebody for an hour, prevented patient. And we're finding that's returning quite frequently because they're changing their formulary because we can't carry propofol. So with working with the hospital and credentialing these paramedics to be able to continue that. As far as paralytics like, you know, sucks or rock, we're not looking to carry that. Again, that's something that can be, you know, revisited down the line if we were going to look at utilizing MFI in the field. But we're not looking to chemically paralyze and MFI anyone on a 911 call.
I'm not saying that. I mean, we've done SCT for years, and I can tell you, and nothing against the hospitals, one of the biggest things that we find is that patients are great in the hospital, where they may be sedated enough in the hospital, but for ambulance transport, they're not. And we may choose to rock a patient, or to even turn up the prop or bolus prop, you know, as needed. My question becomes, and I don't know, we're a little different. We carry this stuff for that reason. If something bad goes wrong during transport, what do you do? Or if like our standard of care says when we go into a hospital, we're no different than LifeNet. If we feel a patient needs to be intubated, we may intubate a patient, whether it's in the hospital or not. And we use our stuff. We don't always, just a word of advice, we don't always get the cooperation of some doctors.
Sure.
Or the doctor may not be available, especially if you're coming out of a unit, a doctor may not be available to do that. So our medical control physician has approved a standard of care, no different than you would see at LifeNet.
True, and our protocols are listing the standard care as well, and I understand what you're saying, that if we're getting prop drip from the hospital, you know, things can go bad, that patient can come out of it, you know, and we do have the transport orders do allow for altering slightly that prop drip, but again, if the prop drip became unviable, we're back to where we're currently at, which is
my only fear is not having the medication. What I'm saying is I think you should at least apply for the MFI, whether or not you, as an agency, you choose it in the field to do it or not, you should at least carry the medication.
That's true, that's something we're visiting the line, but right now, all our patients that are vented are being transported on fentanyl and Versed. So we're looking at increasing our level of care by allowing that probe drip and adding that modality on there from the hospital, so we can transfer that patient. If the probe drip became unviable, we're back to fentanyl and Versed, which is where we're at right now.
Right, let's back it up to a higher level. So you have a proposed curriculum with the two medical directors, one in the hospital and one is your agency level. And this is for paramedics to utilize in interfacility transports or critical cares to do it, or what level?
Strictly for interfacility.
And at what level though? Paramedic?
Paramedic.
Okay. All right. So does anybody need? I don't think this is not a defined curriculum, so it's something that you're defining with your medical directors?
Well, can I just point, under the protocols that are currently in place right now, the collaborative protocols, and this is the 15 version, not the version that we're going into, but it says critical care technicians and paramedics that have attended regionally approved supplemental training focused on specialty care transports and have been credentialed by the agency's medical director may transport a patient between hospitals with other IV infusions and advanced modalities, provided the medication is ordered and provided by the transferring physician or facility. All medications and interventions utilized must be covered within agency protocols. Be certain to clarify orders regarding medication titration prior to departure. The IV medications must be run on an infusion pump and that provider is trained to operate. See New York State DOH regulations for blood transfusions. So the way I read this is you can come here and talk until the cows come home. No offense to you country folks, Maggie. But until you guys present something in writing to the REMAC, you really can't do this. I mean, I see you said that you put everyone through this training and stuff, but you did it without the approval of the REMAC or the region.
Well, it has to be approved here. So
Correct.
what
Training has to be approved.
You're suggesting that this group get a look at the curriculum.
They get a look at the curriculum and at the protocols. I mean, that's the way every other region has done it for the SCT. They're brought before the REMAC, and the REMAC takes a look at them, because sometimes something that may seem simple.
Usually what happens, at least in Remo on a regular basis, because I sit on a committee down there that it gets in front of, is the agency medical director and the ALS coordinator will come to the region and together jointly ask to start an SCT program, and then they'll bring with them the training curriculum that they've got and how to implement it and the protocols and policies, procedures. Sometimes they'll come with written letters of support from a contracting facility, and then they'll actually get a approval / blessing, if you would, from the down there it's academic committee and then the REMAC, and then they can go forward with
So
training.
where are you guys at in this process now? Are you at the tail end of the process? You've had your training, the curriculums?
We're about 85% done with the training. The training curriculum we did submit with our letter of intent, with the didactic hours submitted, and the requirements for paramedics to be accepted into the program.
Right, but you still lack the REMAC approval for this, right?
Usually the training and ed, well, it sounds like you guys are using one of the two. Which curriculum are you using?
International I gotta look to see what it was. There was the two main national curriculums, both of which are almost entirely identical.
And then usually east of here they'll have a paramedic level CIC deliver the material, or a physician.
Yep, and we have 3 CICs within our agency. We also have respiratory techs, Nick Latour, and physicians who have agreed to sit down in the labs and do the work.
So what I would suggest at this point, since you guys are 85% done with this, would be to have the medical director, your agency medical director, just forward a copy of the curriculum that you guys went through, and a letter of support to Phil, and Phil can circulate to the REMAC, and we can probably vote outside of today's meeting. Does that sound like a reasonable approach?
They did supply the curriculum.
I know we do the curriculum, no center on the other day, yeah.
Right, so they did supply that.
Do we all have it?
I sent that out by email to all the REMAC members 2 days ago.
Okay, 2 days ago.
What about the agency protocols that they're gonna be operating under?
I don't have a copy of those.
Because like, I know even Deb Funk with AAREMS or LifeNet, I mean, they questioned some of the modalities there just because a fresh set of eyes did wonders.
So this curriculum turns into defined protocols for certain.
Correct. If you read this, the agency has to have defined protocols. Do you guys have those protocols done?
Dr. Glenn has not signed his full signature to the end of it, so we haven't released it. We do have them.
All right, so it just sounds like we have the curriculum.
We didn't want to release anything for
Until you're complete.
pending like an actual signature.
All right.
on it. But he has looked over them. It has been approved. He's just got to. It's just a matter of tracking them down to get them.
But they haven't been approved by the REMAC.
Right. So what I would suggest
I don't
would be.
necessarily know that the standard of care does not have to be approved by the REMAC.
Right.
What they usually do is the classifications of what they're going to be doing.
Right, I think that the REMAC should look at them, no question about it, and that's what we did years ago. I just don't know if that they necessarily approve because you're an extension of the hospital at that point. So there has to be certainly a comfort level between Dr. Glenn. I think that it's important that we need to know what the QI process is going to be. I think that certainly if they're doing crazy things, in the field, if they're going to do a pericardial synthesis or something by far chest tubes or stuff that's really out of the scope, then a fresh set of eyes can question that and certainly have a sidebar conversation with Dr. Glenn whether or not he really wants to allow it. But I don't necessarily know if REMAC approves the standard.
Well, let's just back up. So what I think I'll just suggest something, and the REMAC can chime in. A letter of support from Dr. Glenn. We can recopy the curriculum for protocols once the protocols are wrapped up. So Dr. Glenn's cover letter saying, I recommend REMAC approval for the protocols. Here's the attached curriculum that they've gone through, and send that to Phil, and Phil can get it out to the REMAC, and we can vote on that bundle.
What it says in the protocol that we read in the bottom is that credentialing must include a regionally approved training component for the SCT.
Well, they're a little bit ahead of the game, right? So.
Well, and that's the point I was trying to make. Because they're doing the training
So I think that,
before it was approved.
I think the REMAC can accept
But it can be
reasonably
approved
accept
before
the national curriculum for SET. There's no question. I mean, this is almost identical to what we did, and we follow the national curriculum. I think that
Joyce isn't
not to
here.
support.
It's the critical care paramedic curriculum.
Almost identical to the Baltimore program.
I just
Well,
make the
yeah,
suggestion
it's
that it goes to the Training and Ed Committee here. That's normally where we go first with a recommendation coming up.
Okay, so that's an additional request, that the same material will go to the Training and Ed Committee. All right, any further discussion about that? All right.
The next item is that Morris Emergency Squad has returned to BLS level of service on October 10th, and that's purely informational. They just wanted us to be fully aware of the situation with them.
And these are loss of individual providers probably, right?
That's correct, yeah. Then we have an update on the status of AAREMS BLSFR agency recertifications from Mr. Farrell.
First, we have to clarify that BLSFR agencies are not certified, so you can't be recertified.
Sorry,
It has to be an update.
update. I stand
As
corrected.
it stands right now, there are five or six agencies who receive the final loan. That means they have less than 30 days to comply, otherwise they're going to be archived. Again, they don't have to stop responding, but they won't be able to be part of the CME program and or apply for reimbursement. So there's five agencies with five. As far as recertifications and inspections, everybody in our is up to date.
Oh, excellent, okay. Very good. We have not received any correspondence that necessitates an executive session. This is like 3 sessions in a row where we haven't had an executive session. do have another piece of new business. First of all, two pieces of new business, actually, that this is not confidential in the least. Dr. Fisher is undergoing surgery this morning. He has a quadriceps tendon repair on his left leg. And like I said, this is not confidential at all, but he advised me, very heartfelt, and I certainly agree because I had the same thing happen 10 years ago to myself. He'd much rather be here than on the operating table, and that's where he is this morning.
So this is his excuse, right?
Yeah.
So just tell him we're gonna need a letter from his doctor.
He wanted to know how my recovery was. I told him it was, thank the Lord, uneventful. I'm sure his will be too.
Is he gonna share how he did this?
He did not say. I exercised discretion and did not ask him. I fell on the ice. That was no secret.
It's a lot of force.
You stepped in a hole.
Yeah.
My ambulance squad.
That'll do it.
The worst patient they ever transported.
Did he cut himself? Is that what, his chainsaw injury?
No.
Just the mechanical stepping in the hole. That's better than the chainsaw with it. All right, any other business?
Yes, we have a letter from the Richmondville Volunteer Emergency Squad addressed to Dr. Leinhardt and the REMAC. Just got it this morning. It says, "Dear Dr. Leinhardt, this letter is to request that RVES be allowed to change our level of service to the AEMT level effective the 1st of January 2017. Currently, we are at the paramedic level. We have discussed this with our medical director, Dr. Funk, and agree that RVS's current priorities are rebuilding our BLS staff. Once that is accomplished, then we will most likely revisit the feasibility of providing paramedic level service again. Sincerely, Ed Hillenbrand, Captain." So I'm presenting this to the REMAC for their consideration and approval that RVES, Richmond Volunteer Emergency Squad in Schoharie County, return to the AEMT level, or drop back, I should say, to the AEMT level of service on paramedic level due to staffing issues.
Okay, so we're informed. It's really informational. Thank you.
Okay.
And Howard, you had something?
And Howard has
I think it's going to be quick, but we'll see. I sit on a small tag with the CMAC in order to discuss the critical care level in New York State and come up with ideas as to where it might go in the future. And each of the tag members were asked to basically go out to their regions and asked and survey for opinions. So I'd like to open up to the MAC, and later I'd like to open up to the REMSCO also. But specifically physicians in the room, you know, the main questions have come down to first, keep EMTCC or not, and then after that, if we're not going to, then how do we adapt to that? And if we're going to, how do we accomplish that? So I don't know if anybody had good feedback in the room or would like to put an opinion out there.
Well, the Electoral College of Critical Care, I think we're overwhelmed by Nassau, right? I mean, it's just, doesn't matter too much what we think unless we're going to go it alone as a region. You're talking about at the state level?
State level.
Yeah. Every time this has been surfacing for like 20 years. Nassau County comes down pretty in favor of maintaining critical care from here to eternity. So I don't think.
But they have to get narcotics on all their ambulances in order to do so.
I was going to say, I think at this point, this is real. You know, I've heard it for 15, 20 years also. And I think this is real. And to provide a little bit of background, the CC curriculum is hugely out of date. And just the person, man hours, whatever you want to call it, to even attempt at fixing that is huge. And there is no national model to use for CC. It is a New York State only certification. You know, when you look at hour comparisons, you're looking at about 500, 600 hours to about 1,500 hours, 1,400 hours for paramedic. Again, I'm just kind of looking for physician ideas.
How does Nassau County approach it? What are they going to do?
You know,
are they prepared to go paramedic for control?
So here's the thing. A lot of people in discussions have been talking about Long Island as a whole, right? Long Island has things that we don't. And there's a much larger portion of the state that we really need to think about, specifically our own regions. And there's been recent discussion regarding CCs in rural areas actually being possibly detrimental to patient care because low volume providers with lower education with extended transport times makes for an ugly situation sometimes. And Nassau County has a fair amount of hospitals in a short amount of drive, especially when compared to regions like ours and Mountain Lakes.
So you think this change, if it's coming, may happen region by region?
I don't know. We've been asked to basically sit down and come back to the CMAC in spring with an idea as to whether we the state, should keep it or get rid of it.
Or does it go state region by region?
Well, and then it goes from there. I think they're really looking to approach this as a state approach. So, you know, physicians, I know you guys have a fair amount of involvement between paramedic and CC levels. What are your thoughts?
Understanding there's a huge difference in training. I think it would be devastating to do away with them at this point in time with a lot of districts in a lot of areas because of the fact then you would have nobody. Or you might have a basic coming with somebody who's critically ill. The elevated level of training is a positive versus you got basics or nothing.
Yeah, I know that's been a couple of comments from Mountain Lakes area, and the thing that ended up being kind of a counterpoint to that is that the AEMT level has not really been publicized and explained well. So I believe Andy Johnson from the state had done some statistical research on medications pushed by CCs and the amount of volume and where they're doing it. And when you start looking at some of the data, because that was my original gut instinct too, we're going to have huge holes of care in places. The numbers I can't say necessarily supported because AEMT provides a lot of those emergent procedures, medications, etc. Doesn't provide things like pain management. So, you know, they're looking at possibly supplementing with some distance learning bridge paramedics material and AEMT level agencies, but that was one of the first concerns.
Yeah, I think, you know, historically, New York is a little bit of an outlier.
In everything.
Well, historically, budgets are forcing them to be not an outlier because if you remain an outlier, you have to create your own new critical care curriculum. You got to do the whole 9 yards. State, in my experience, has been basically conforming to the rest of the nation. For example, the state used to have their own internal process for approval of trauma centers. They're completely out of that. They hand it over to the American College of Surgeons, and they take their recommendations. So when there's a national curriculum that doesn't, talk to critical care, I mean, one approach would be to phase critical cares out, so they move into either AEMT, which is a confusing term for me, or medic over time. So you give them, bridge courses, et cetera, to move either up or into a different category that then conforms to the national curriculum, and the state can kind of get out of the curriculum business because it comes at a national level.
Is the state prepared to assist with the bridge programs by vouchering, as they do for, because it's hard to say, well, to push people to go to paramedic when they have to pay tuition, which is a large fee, but then there's this CC program that they can do, the state will voucher for, and they can go to it, at no cost. So it's hard to say we want this, but then we're going to make it difficult. So if they allowed the same vouchering for paramedic classes, I mean, that could be an incentive, more of like a carrot than a stick to get them to switch over.
Right.
The limited education opportunities, as it must be with a university. What's that going to do to the student output?
All good feedback and all things that have been discussed from other regional representatives also. That's why, at least decision-making tree, it's been really, is CC a good level of care for patients in New York? And then after that, I think that we're going to be tasked with trying to figure out how to meet some of these issues, because obviously they're going to be there. And I think you bring up really valid points. points. I think it's one of those things where we need to find ways to make sure that if we're truly going to say, okay, CC isn't going to exist in 5, 10, 20, whatever time frame happens, years, what's the mechanism going to be able to still bring providers to a level of care and agencies to a level of care without shorting ourselves?
So are you fact-finding, or are you suggesting a motion?
Opinions, no motion. No easy stuff, just discussion.
So
any of the other providers?
Howard's acting as our conduit to the state, to the CMAC, actually. Is this a tag of some sort?
Yeah, it's a tag.
We specifically chose the AEMT level after discussions with Dr. Funk and realizing our county, we have other resources for paramedics that we mutual aid in anyways because of the narcotics. The AEMT provides, as was said, the quick emergent medications very fast, and then for anything else, they'll be there. It's resources and money. Thinking about the southern tier and such, they're going to have to do the same thing. The cities have paramedics, and the rural areas, it's very scarce because of money. That's always our state.
As narcotics are so mandatory in the big picture now, and more important than ACLS.
So is Narcan, by the way.
Yes, yes.
That's over the counter, though.
Yeah, this is such a critical event to have morphine on an ambulance versus having amiodarone on an ambulance. How come at this point, it's going to force people down to an AEMT level, which would not be able to carry narcotics? I guess I'm not seeing the big picture here.
Not just narcotics. I mean, I always worry about the anticonvulsants that are in that controlled substances category.
As far as pain management, I'm sure somebody somewhere in Ireland is going to cringe as I say this, but there's still a mechanism to use nitrous as an AEMT provider through New York State. It's not part of the curriculum, but there's definitely a mechanism to do it. So there is a pain management option in there. I think Dr. Leinhardt's point is pretty valid, though. For me, I'm a huge proponent of properly pain managing patients. However, patients without pain management usually live. Patients who are in status seizures have a little bit more trouble with that. So I completely understand it. I don't think that there's going to be a perfect fit no matter what. I think the hardest thing is that they're really trying to get information from regions and not only get a regional view, but what fits best for the state. Now, that's going to be really tough because we're broken into separate regions in the first place. And I think even within regions, we have almost sub-regions where, just like AAREMS, you can look at things like the Amsterdam area versus Harry County versus Cooperstown, and you've got 3 very different areas of EMS. Yet we need to find something that fits either a state or a national model that's going to be able to be sustained down the road, and frankly is good for patient care.
So you're just looking for email responses? From
Yeah, feel free to shoot
the
me, grab me,
majority
call,
here.
whatever.
Phil, what are our numbers for critical cares versus medics?
We have about 50 critical cares. I'll give you that exact number this afternoon. I have to pull it out of the computer.
Thank you.
But we've got about almost 5 to 1 paramedics compared to critical cares now in our region.
It's shifted like in the last 10 years quite a bit.
Oh, that's in the last
The-
5 or 6 years.
The other piece of it, which Howard didn't share, Mike McAvoy is one of the chairs of this committee. I was at a presentation that he did, and he showed the number of people that test or recertify at the critical care level. And it plateaued about 10, 15 years ago. I think the last year that there was numbers for was either 14 or 15. I mean, we have numbers, but that he had on his slide presentation. And there was maybe 300 that either recertified or credentialed across the state at that level.
I can tell you just esoterically, I've canceled our last 3 rapid refreshers for CCs because we have had 0 enrollment. And that's free. So, but again, just looking for feedback. Andy Johnson's pulling together some really good, hard, clean data with help from the regions, and I just want to make sure that we can put some tissue with the issue if you think.
Back in the day, the state made it extremely user-friendly to bridge up from critical care what they used to call cardiac care technician, up to paramedic. And I frankly never could understand why they made it less user-friendly over the years, but if the state were to offer some really user-friendly bridging, I think you'd see a lot of folks take advantage of it.
I can tell you exactly why, and Debbie Cuffs can probably add to it also, but she and I were both working at Hudson Valley at the time, and we had been shared to try and create a bridge curriculum specifically when REMO went through this and said, hey, we weren't going to offer original CC education anymore. And the problem even then, especially now after paramedic program education standards have been increased, is it's not so much the skills, it's that, and Maggie can speak to this also, is that the CC curriculum as is covers about the first third of education for all of the topics. So it's not like you can turn around and go, okay, every critical care tech can intubate, so you don't have to teach intubation, because RSI is a national standard now. So every paramedic going through school needs to cover RSI. It's a national standard. Acid-base balance comes in with that. There are some things now that are in the AEMT ed standards that are actually not taught in the critical care curriculum. And there's such a huge difference that you can't simply go, okay, these three things are done in CC, so we don't have to teach it in paramedic. It's about deepening the education on almost every single topic. It's tough.
When was the last time that critical care curriculum was revised?
98? 96?
So the message I'm kind of hearing is the state has no interest in revising the critical care curriculum, or unless told to by the parties that they.
I was going to say, I think, genuinely, I think they're keeping an open mind about it, but they truly want to make sure that the data backs up and supports it, because it looks like right now it's going to be an awful lot of work to do.
Here's the other piece of it. It doesn't carry over into any other state.
Right.
So if New York State were to revamp the curriculum, which we don't provide curriculums anymore, we give you standards. So if we were to revamp the standards, how do the instructors make that bridge?
Right, the REMAC would be at it for the next 3 years. It's revising the curriculum.
Yeah.
We're using the, having them do A&P, and then as far as the basis, and using the paramedic challenge refresher to judge, because it's one CC here is not, it's not equivalent to another CC. A lot of people have gone above and beyond, so you can't, it's not just one, okay, CCs, this is what their education level is. You know, they took it years ago, it was much higher, you know, it all varies.
That's exactly, that's
so
a
you
great
cannot
point.
say, here's the CC program, let's make a change.
That's actually part of the problem, because so many folks, and I know Maggie and I have had this discussion, so many folks that run CC courses that are paramedics teach above a CC curriculum, and that's actually problematic, because what you're doing is you're going above and beyond, and then putting a provider out there that's still at that level. So when you make a change statewide, because we talked about this, some CC classes are great and they go way over content, but they're picking and choosing what to go over content for, and it becomes this mishmash paramedic CC hybrid. And statewide, if you're going to make a change, you still need to base it on the entry-level competency and the curriculum
But
at
across
hand.
the board, the one common point is they don't have the anatomy and physiology 1 and 2.
Correct.
You know, so if you just chose that as a basis, having to do that, and then use a program that's already in place, having to do the paramedic challenge refresher, and you can identify what areas that they're deficient in, and run them through in coordination with the paramedic class already running. I mean, rather than reinvent the wheel and try to come up with some bridge program, when you already have a challenge refresher program already in place, you know, allow these people to voucher to do this over a course of time, do the A&P, and then, you know, go in and do a challenge refresher at no cost to them, and then I think you'll have a huge amount of people taking the opportunity. Like Phil had said, you're making it a little bit easier for them.
The exact educational concept that you're describing is exactly what Hudson Valley and SUNY Cobleskill Paramedic has been doing for at least the last 20 years. 15 at least.
We've both
tried it, and it sounds wonderful on paper. There's a couple of problems, and one is, okay, today is a basic cardiology lecture, and the CCT has 1 hour of that cardiology lecture under their belt from their initial education and what they've demonstrated, you know, in terms of testing and training and skills. So they have to come in for the first 45 minutes, then they get an hour, and then they have to come in for another hour and 45 minutes to finish it up. And it's very difficult to slot people into those in an existing paramedic program, because so much of the paramedic program is into the why are you doing this and when should you not do this types of information. Certainly has been tried. And students have come to both programs over time. Well-motivated students have come to both programs over time, but it has not had the onslaught of people breaking down, at least down at Hudson Valley, and I'm sure, I mean, SUNY Coldskill is still standing, so I don't think they broke down your doors either.
I mean, it could be that publicity of that program, just like you said with the AET. I mean, people don't know they can avail themselves of that. But as far as deficiencies in learning, I mean, it's no different than some paramedics who have taken the class and just restarted with CMEs for years and years. And we all know the pilot program is great and we all love it, but I mean,
That's
let's be
another
honest.
conversation I won't be
Yes,
baited
that's-
into.
I would say, I don't think you want to go there.
Some people have been paramedics for years and are a little lacking in their knowledge base.